Focused cardiac ultrasound FoCUS is a simplified goal-directed point-of-care ultrasound POCUS examination performed by ICU clinicians. Unlike a comprehensive echocardiogram, FoCUS is designed to answer specific clinical questions. Is there a cardiac tamponade? Is the LV failing? Is the patient fluid responsive? A standard FoCUS examination consists of 5 primary views. Each provides a unique slice of the heart to evaluate function and anatomy. In the parasternal long axis view, often called plaques view, the probe position is in the 3rd to 4th intercostal space left of the sternum. Marker is towards the right shoulder, marker on the probe. Left atrium, left ventricle, right ventricular outflow region, aortic and mitral valves can be seen in this view. It can assess global and regional left ventricular function, aortic size and pericardial effusion. This echo clip shows hypokinesia of mid-androseptal region. The segments seen in this region have been marked mid-androseptal, basal androseptal, basal posterior and mid-posterior. You can see right ventricular outflow tract, left ventricle, aorta, left atrium, mitral leaflets and aortic leaflets in this view. Next view is the parasternal short axis view. Rotate probe 90 degrees clockwise from the plaques view, marker to the left shoulder. Left ventricular cross section and right ventricle can be seen. Regional wall motion abnormalities. Left ventricle will have a donut shape and right ventricle will have a semi-lunar shape. But when there is a pressure overload, it will be a D sign. This shows regional wall motion abnormality. Mid-androseptal region is not contracting as well as the other segments. You can see the papillary muscle on one side clearly, which is jutting into the cavity as a slightly more echodense region. This picture illustrates the change in shape of left ventricular cavity in severe right ventricular pressure overload. Hypertrophied right ventricle with higher pressure has compressed the left ventricle into a D shape instead of the classical donut shape. Apical 4-chamber view can be obtained by placing the probe at the point of maximal cardiac impulse, usually in the 5th left intercostal space, and the marker is pointed towards the left axilla. Key structures seen in this view are left ventricle, left atrium, right atrium, both interventricular and interatrial septa. But there could be echo dropouts in the interatrial septum as the beam is going parallel to the structure being imaged. We can compare right ventricle versus left ventricular size, assess contractility and valvular flow in this apical 4-chamber view. 2D echo clip shows the regions which are hypokinetic due to myocardial infarction. Papillary muscle is seen. Mitral and tricuspid valves are seen opening and closing in this view. The color Doppler sector is placed over the mitral valve. You can see the flow in red color from left atrium to left ventricle. It is shown in red because it is towards the transducer placed at the left ventricular apex. Slight rotation of the transducer in the same position will give you the apical 5-chamber view, which includes aorta also. You can see the aortic valve opening and closing and the left ventricular outflow tract flow into the aorta. The flow is blue in color because it is away from the left ventricular apex, the position of the transducer. There is mild turbulence which shows as variance in the color pattern. If you look at the aorta, distally there is some change in color pattern because it is slightly higher velocity when it flows across the aortic valve. If there is a large pericardial effusion, it will be seen in all views. You can also see that the heart is swinging to either side in the pericardial cavity in the two frames illustrated. Classical sign of cardiac tamponade in pericardial effusion is diastolic collapse of right-sided chambers, right atrium and right ventricle. Subcostal view is also known as subxiphoid view, is taken from below the xiphoid process angled towards the left shoulder. All four chambers can be seen through the liver. The structure seen above the heart is the liver. It's best view for pericardial effusion and tamponade. In this picture there is no pericardial effusion. If there is pericardial effusion, it will be seen as echo-free space around the heart as seen in the previous image. This view is good for imaging the interatrial septum, as the interatrial septum is perpendicular to the beam of ultrasound. Inferior vena cava can be imaged from the subcostal view by rotating 90 degrees clockwise, marker towards the head. You can see the inferior vena cava entering the right atrium. It is very useful for assessing volume status and fluid responsiveness. Interpretation: key clinical findings. In the ICU, interpretation focuses on binary or qualitative assessments. Example, yes or no, whether left ventricular dysfunction is present or not, or pericardial effusion is present or not. In the assessment of left ventricular function, if the left ventricle is hyperdynamic with left ventricular walls almost touching each other in systole, what is called as kissing papillary muscles, because papillary muscles are the ones which are jutting into the cavity, often seen in hypovolemia or distributive shock in sepsis. On the other hand, it could be severely depressed, minimal wall thickening or inward movement in the left ventricle, suggests cardiogenic shock or acute on chronic heart failure. Normally, right ventricle should be less than 2/3 the size of the left ventricle. If the right ventricle is larger than the left ventricle, suspect pulmonary embolism or acute right ventricular failure. In parasternal short axis view, if the interventricular septum is flattened, making the LV look like a D instead of the O shape, it indicates right ventricular pressure or volume overload. Pericardial effusion is seen as anechoic black space around the heart, marked as PE in the image. Right atrial collapse in diastole or right ventricular collapse in early diastole is a feature of pericardial tamponade. That is a medical emergency requiring immediate intervention by pericardial aspiration. Looking at the inferior vena cava is very important for assessment of the volume status. A plethoric IVC with diameter more than 2.1 cm with less than 50% inspiratory collapse suggests high CVP, fluid overload, tamponade or right ventricular failure. A collapsible IVC diameter less than 2.1 cm with more than 50% collapse could suggest that patient may be fluid responsive in the setting of shock. So it is ultimately the assessment of volume status by looking at the IVC. The picture shows a plethoric IVC joining the right atrium. FoCUS is rarely used in isolation. It is typically part of broader diagnostic algorithms in the ICU, like rush protocol. Rapid ultrasound in shock evaluates the pump, that is the heart, the tank, that is regarding IVC and fluids, and the pipes, aorta and conditions like deep vein thrombosis. In deep vein thrombosis, when there is pulmonary embolism, on echocardiography you would expect dilated right-sided chambers and pulmonary artery, as well as sometimes, very rarely, you could see embolus in transit through the right heart chambers. FATE protocol, Focus Assessed Transthoracic Echocardiography, is a systematic approach to rule out the most common causes of circulatory failure. Please note that FoCUS is a screening tool. If you find significant valvular disease or complex pathology, a formal comprehensive echocardiogram by cardiologist is indicated.